Hello, everybody, and welcome to the Polestar Pilates Hour. We're coming to the end of January of 2026, and I have a super exciting topic today. We're going to talk about the brain and concussion. So I'm an old school presenter where we always tell people what we're going to talk about, then we talk about it, and then we tell you what we talked about. So concussion discussion. I have a rhyming thing today. I think it has to do with my own brain injuries in the past, but understanding the anatomy of the brain a little bit so we understand what's actually going on. We'll define what a concussion is and how to differentiate it from other types of brain injuries. We'll talk about some of the risk, lasting effects, and limitations from concussions and understanding symptoms and also debunking some of the common myths about concussions. And I do want to preface this. I have a good friend who recently was involved in a motor vehicle accident and had a closed head injury, concussion. And I guess that's probably what spurred me on to do this subconsciously, because I was asked by Melissa, who runs the webinar for us, we need a good topic for pathology. And I said, immediately, concussions. We're going to talk about concussions. And I think it was because this friend of mine was on my mind. So let's get going into the details here. So background on concussions. A concussion is a brain injury triggered by a blow or a jolt to the head. And I'm going to talk in detail about that because there's a lot of misunderstanding of some of these injuries, typically thinking of it as an acceleration and deceleration. This is the CDC's definition. And I think the new research is giving us some more information about it of what actually is going on with these acceleration, deceleration injuries, where we used to think it was about the head, the brain hitting the skull forward and then back with like a whiplash injury. We're going to talk about that. 1.6 to 3.8 million concussions are diagnosed yearly in the United States, 30% in pediatric patients. Most of those are related to sports. Sports, bicycle accidents, skateboarding accidents, swimming pool accidents. That's why we see such a high incidence in pediatrics. I know that I was taken to the hospital a couple times as a pediatric patient for concussions from things like falling off of a cliff 40 feet and hitting a rock in the water. I have definitely had my share of brain trauma. Sports injuries are the cause for most pediatric patients to be diagnosed with concussions, according to Hobbs et al. Let's keep going. Classifications of brain injuries. Now, traumatic brain injury is a whole field of medicine, emergency medicine, rehabilitation, occupational therapy. It often lasts for a long time. And probably the most interesting thing about it is there's no two head traumas that are alike. The brain is incredibly complex. And so there's some people, like you've seen pictures or videos of somebody that has a nail in their head, and they go and they end up having little to no kind of long-lasting side effects of having a big nail in your head from a nail gun, where others have had, just a fall, and they hit their head in a certain way and have had some permanent damage to the brain. So we're going to talk a little bit about some of these different types of head injuries. Skull fracture is probably what we are most familiar with, and how that skull fractures or is penetrated determines what kind of injuries we're going to see, right? And so when you have a focal injury, that's going to be a more specific site. So like if somebody hit you in the head with a hammer, that would be a more focal injury versus a significant fall or being involved. Some of the cases I've read recently were people involved in earthquakes where the building has collapsed and their head has sustained a long period of pressure that has led to brain damage. But it's not just caused from a blow like a car accident or a motorcycle accident. Penetrating injuries typically are talking about things like nail guns, bullets, other things that would, like you've seen, just accidents, people falling down and hitting their head on some rebar in a construction site. Those are penetrating injuries where something literally goes through the skull and into the brain. And again, every single one of these injuries is distinctly different, and they respond differently, right? We know that sometimes just from a blunt trauma to the skull that caused a fracture, that it's the bending of the skull that actually caused the subdural hematoma, and that bleed, it's more the vascular system that actually is putting pressure on the brain. So you'll see emergency medicine often do something where they'll drill a hole to drain that area to make sure that they can take the pressure off of the gray and the white matter that are involved in that subdural hematoma. Blast injuries is another one that's common. This is what we see still a lot in our vets coming home that were exposed to a lot of explosions. And the explosion, the percussion of that often causes them to lose consciousness. On top of whatever other injuries they have, the brain does sustain an injury from that blast. Diffuse brain injuries, and the mildest form of that is what we refer to as a concussion. This by far is the most commonly injured substrate in diffuse brain injury is the axons within the white matter or the neuronal cell body. And we're going to talk about that it's the translation or the shear force between the gray and the white matter that actually damage or hurt a stretch injury to the axons themselves. And this reason, the prominent forms of diffuse brain injury are diffuse axonal injuries, known as a DAI, and ischemic brain damage. And what that means is sometimes the brain is not receiving the proper either neural impulse or vascular supply because of these types of damage. So when we look at the mechanism of injury, here's a couple, just a little more detail. I don't want to get too gory with this. That's not the intention of today. But static and quasi-static loading, this is what I was referring to in the earthquake or building materials or somebody being stuck underneath a car. I've seen people getting run over or hit by trucks or buses, and there's some kind of pressure that falls on their head for a long period of time. So that would be a static or quasi-static loading. It's not necessarily the amount of pressure, it's the duration of the pressure on the skull that can lead to serious trauma or even death. Dynamic loading is more like what we see in our football injuries or the cases where a parent is shaking their baby, that there is the sort of the brain sloshing around inside the skull is more of a dynamic loading. And that is not necessarily impact. Nothing necessarily hit the head. It could be the whiplash kind of injury in a car that would cause the brain tissue to hit the walls of the skull. The impact one is where there is contact force, and it also is inertial head force. So, for example, if my friend was in a car, went off the road, head hit, we think, the airbag, but it was the sudden stop that the head hit the airbag and revert back, that was the impact and the inertial injury to the brain causing a low-grade concussion. This could result in fractures, and it also can vary with the size of the impact from these contact loadings. So this is where, again, if you ever watch some of the murder mystery shows, the detectives have to try to find out what kind of weapon was used in that injury, right, or in that killing. And so they look at the size of the perforation, the size of the fracture. Was there a lot of skull bending that caused a hematoma? How long did they live before they passed away? If it was a murder mystery, which I do like murder mysteries. Distorting or straining of bone or soft tissue beyond their functional or structural tolerance. So this is another mechanism where, again, different types of falls where the head hits the ground and there's something like if they hit a pipe, it doesn't necessarily fracture right then and there. It might just be a deformation, but that deformation of the skull can cause some trauma to the underlying tissues. Strain or deformation is considered the proximal cause of tissue damage. This strain can cause alterations in the functional or neural circuits and receptors and changes in the properties of neural tissue. And that's really what we believe is going on in a concussion. It's more the disruption of the neural circuitry, typically between the gray and the white matter of the brain. So let's take a look a little deeper. Another aspect that we don't often talk about or I don't hear about, but it is very popular in the concussion discussion, is rotational acceleration. So when we talk about typically concussions do not seem to be caused with that sort of whiplash kind of injury. There typically has to be a shear force that's happening, and that's why rotational and also oblique kind of forces to the head tend to have more association with concussion-related injuries. So rotational acceleration is a very important, highly injurious mechanism because not only does it produce the high surface strain seen in translation motions, but it also is the only mechanism capable of producing high levels of strain deep within the brain itself. And so that's what it's that shear force that we're concerned about. So this is when you see the football injury, American football, where they're just going in this deep head banging contact, but they also have a little bit of like a whiplash as they're thrown down onto the ground. And so they get a jolt and a rotational, typically coming from the neck. We quite often see concussions associated with neck injuries, motor vehicle accidents, fractured cervical spines will often be accompanied by this rotational type of damage to the brain. And again, just to put people at ease, 70% of concussions get better automatically. Like they're going to get better on their own. So there's a high success rate of getting better with concussions, where traumatic brain injury can be very different. All right, let's keep going. And I have an image here sort of showing the difference. Linear acceleration would be just sort of like the whiplash forward and back. The rotational usually it needs to come down into the neck, at least into C1 and C2 where rotation exists. And that rotation also will put a tension. And if you see my little arrow here, the rotation will put tension down on the brain stem. And that's also dangerous that we know about as well, that can cause some additional torsion and shear force. That's what we're trying to avoid. These are the different types of forces that we could look at where there's considerable tolerance to compression and tension, but where we don't have tolerance is shear force. And shear force seems to be the demon in the concussion. And when we look at angular acceleration, I'll show you an image of that in a second, what we're seeing is that the shear force on the angular rotation, actually I will just show you that in this rotation where the head gets hit and it has a rotational and an angular acceleration, which often happens from seat belts. So if you think of the seat belt being on you and you go forward and your head will wrap around the seat belt and then you get hit with the pillow that prevents you from going through the windshield. So that's the most common kind of cause of concussion. Or when you fall down, your head will also go through one of either the rotation or the oblique kind of axes here. When we think of the injury itself, and this is important for us to understand, is think of how you see the gray matter and you see the white matter, and they have different densities. They have different tissue thickness. And so the axons communicating between the white matter and the gray matter, often in that space, when they get sheared, when there's a shear force, that's where the damage happens to these axons. And these axons then go, and you can see here as well, like here's the gray matter, here's the white matter. These are the dendrites of the axons, and that shear force does more harm to them than just acceleration going forward and back. The rotation of that tissue moving, and the white matter is going to move faster or slower than the gray matter, is what's going to create that torsion or that damage to the cell. And so what we've learned is that in most concussions, it's a temporary damage to the axons themselves. And it creates what's called a metabolic crisis of the axon. And that's why you don't just automatically get back you feel fatigued, you feel fog, you might have difficulty remembering things, you might have difficulty executing movement and exercising, maybe even going upstairs. You might find that you fatigue incredibly fast. What's typically happening here is that if we think of our neurophysiology, you think of the action potential. And the action potential is what sends the message down the axon. So the axon's covered with myelin sheath, these fatty nodules, and the voltage has to change to a negative 70 millivolts. And that happens with the work of the sodium-potassium channels, in particular in the nerve axons. So what seems to happen here is that the impulse does not reach that critical zone of negative 70 millivolts. And so the nerve does not pass through the conduction of the signal, which would release the neuropeptide or the action that would be part of that nerve conduction, whether it's a thought or whether it's speech, whether it's memory, whether it's motor movement, doesn't really matter. And that's why we see a lot of these signs. But if you go do an MRI of the brain, you're not going to see a bleed. You're not going to see a disruption. You're not going to see trauma to the brain. But we do know that there is trauma. And we know that because of the signs and symptoms that we see that are related to these axons. And we think that's why, we talk about nerve injuries in the periphery, outside of the spinal cord or the brain. We know those nerves are going to heal and regenerate. So a lot of times, if you've had surgery, your superficial peripheral nerves regenerate. Right after the surgery, it might feel numb or it might feel different. It might be itchy or those kind of things as the nerve is regenerating over that first month. And the nerve regenerates and it does its job and it comes back and almost always has its function. In the brain, we're looking similar kind of thing. If we don't kill the nerve, right? If we just damage the nerve is going to heal. But it's not going to be able to have that action potential that would be normal for that conduction or that communication in the body. How are we doing? Everybody doing okay? Anything? Am I going too fast, too slow? All right. I do have a question here before I go on to the next section here from Katie Santos. So nice to see you, Katie, in the Pilates Hour. I'm curious if a stable, non-moving head is struck by an element in the case of extended trap springs, which does not move the head, can cause concussion. So again, if you think of the blow, whatever way the blow comes into the head, if it comes at just a pure sagittal, it's less likely to cause damage than it is if the blow comes to the side of the head. And remember, it's the brain that's moving, not necessarily the head. So if there's a force, external force that moves and puts force on the head around that axis, that in itself can cause the shear force that we're talking about with concussion. So the answer to Katie's question is yes. Patricia Hurley, one more time with the axon, did you say outside of the brain? I was talking about peripheral nerves. The concussion we're talking about inside the brain. And what the literature is showing is that the axons basically between the white matter and gray matter experience the shear force in the brain. And that's where a tension trauma to that nerve. And then that nerve has to heal in order to be able to do its normal conduction. So the question is, what percentage of nerves get affected with that shear force? How severe was the blow? How much damage was done? And we can grade concussions based on their severity. Hope that helps. All right, let's jump into the etiology and the invisible injury of the concussion. So when we define a concussion, this falls into the category of traumatic brain injury, a functional, non-structural brain injury caused by biomechanical forces. That's the definition. So what we're saying is that there's something that happened. It's not a disease. It's not a process or illness of the brain. That there is some external force or movement force that is causing, that biomechanical force that is causing the strain on the axons in the brain. All right. Recent biomechanical modeling showed that rotational acceleration, as I mentioned, the shearing is more damaging to axons than the direct linear impact. So I guess the take-home message, if you can think fast enough, is when you're going to get in a car accident is to make sure you let your head go straight on versus let it rotate around the the strap. I don't think we can do that. It happens too fast for us. The metabolic crisis. So this is where we're talking about the axon. Energy crisis, where the brain demands glucose for repair while simultaneously experiencing reduced blood flow. So it's just like any tissue that's healing. I think this is the take-home message when we're working with patients or clients that have been diagnosed with a concussion, is that we're really dealing with a metabolic crisis. We're dealing with a healing phase of these axons. And these tissues need time. They need, to not be irritated. So if you're thinking of coming back from a surgery, right, we do a graded load. That's what we're the masters of in Pilates, graded load. We're going to grade the load of the brain function. And that could be motor, that could be movement, it could be thought process, it could be language, it could be, critical reasoning skills that sort of go out the window for a little while, that there's an energy crisis. So while those axons are healing, one of the things we want to do is we want to push up to a level that's sub-threshold. And this should sound really familiar to you because of the way that we use Pilates for all movement pathologies. We use graded load to be able to take somebody to a place that they can experience movement without doing trauma, without causing pain that exceeds their expectation. There's no difference here with a concussion. We're going to do the same thing. We're going to take their body to a level that is something they can experience movement without the fatigue, without any increase in discomfort, without increasing a headache, without changing them. And if you're familiar with a Likert scale, you see this a lot of times in medicine of 0 to 10. So 10 is the worst, 0 is none. And if somebody came in and said, how are you feeling fatigue-wise, 0 to 10, 10 being the worst and 0 being no fatigue at all. And they said, I'm a 4. I'm a 4 today. I'm doing a little bit better. I slept out last night. I'm doing better. In our exercise program, we don't want to take them past a 5 or a 6. We don't want to exceed 2 notches of whatever their symptoms are, whether it's pain or fatigue or tiredness or energy, clarity. So it's a good little tool that you can do. And it's not something that's standardized. It just would be me saying to myself, hey, Brent, how are you feeling today? Well, I feel like my brain fog is a 3 out of 10. Okay. And then I start studying, I work on the computer, and all of a sudden my brain fog goes up to a 5 out of 10. I got to stop. If I'm hiking and walking outside and my body's feeling energetic and I say I'm a 2, and now I'm getting fatigued and I'm feeling like a 3 or 4, I need to stop. If you're exercising and you're working out somebody on a bike or on the Pilates equipment and they get 2 levels above what they came in. So what do you have to do to make sure you're doing the right thing? You have to ask them where they're at with their symptoms before they start their program. And then if the program gets to a point where they're 1 or 2 points above where they started, then we need to stop. The autonomic mismatch, why the heart rate and blood pressure often become uncoupled. This is an interesting phenomena. Post-concussion leading to exercise intolerance. This is something we're going to talk about with the Buffalo treadmill test in a little bit. But the idea is that we have to be very careful of not pushing the load on the heart too much. So those of you that are also involved in cardiovascular training, or you do a jump board class where you're going to have a movement for the full 50 minutes, you need to be a little careful with this population. And I'll explain that a little bit more, but the idea of the heart rate needing to be kept at a certain place and avoiding this mismatch of blood pressure and in the heart rate. So that's important for us as physical therapists. Microstructural versus macrostructural. So this is to remind professionals that standard MRIs and CT scans usually come back clear because the damage is at the cellular level in those axons, right? So a lot of people gaslight people who have had concussions because there's nothing that's readable on the MRI or the concussion on the CT scan. And this is a really bad position to be in, to do that as a medical practitioner, healthcare practitioner, to gaslight what somebody might be experiencing from a head trauma that doesn't show up in MRI. So know that it is true that there is trauma. It's at a cellular level. We're not going to see it on an MRI. We're not going to see it on a CT scan or a brain scan, but it's true if they're having the symptoms following a blow to their head. All right. Concussion etiology. So all gradations of concussion, transient reversible neurological dysfunctions as a result of trauma, are produced entirely by inertial loading. So that means it's the movement. Now, the question was asked by Katie, with very good question, is if you take a blow to the head, can that create an inertial injury to the brain itself? And the answer is yes. So it could be from a start-stop. It could be from an external blow. It could be from the head moving too fast through space. Those are all things that can cause inertial-related trauma. Angular rotation of the head motion causes the deepest structural damage within the brain that deforms that axon layer between the white and the gray matter. For a concussive injury, most of the strain is insufficient to cause structural damage. So we're not going to see bleeds. We're not going to see tears. We're not going to see fluid buildup or pockets around it. Instead, the damage to the structures may be either partially or completely reversible. That's the good news, depending on the severity of the inertial loading, right? And as I mentioned, the damage to the inside of the brain is the shearing of the white matter on the gray matter, and that what we're looking for in seeing is that we're getting a sub-threshold action potential. So that just means that we're not hitting that negative 70 millivolts to send the message, which would account for things like why we get fatigued early, why we would feel that that we're exhausted, brain fog, those kind of things. All right. So these are a couple of things we've talked about already. So etiology, precaution, we're going to go into red flags and some scope of practice, and then we'll spend the rest of the time talking. And I have a couple slides that are just for you to ask questions or to provide some solutions too with the knowledge that we have. Remember that knowledge is king. When we understand how the pathology happens, it takes away so much fear. I hope you're already feeling like, oh, duh, if I understand that this is an axonal injury from an inertia that did not cause tissue damage to the point of where it showed up in the CT scan, and I understand that there's something I can do for it, that I can restore function with them, but I have to be careful and I have to respect how they're feeling that day, then I've done my job. You guys are ready to work with somebody that is recuperating from a concussion. So we're going to talk a little bit about that. I do have a couple more questions here that I'd like to answer. Sarah Edwards, I have not heard from you for a while. Presumably the vestibular system may also be affected. We're going to go to vestibular system, so hang on to your horses. I'm going to go there in just a second. And Katie's back. Given the scans don't show damage, how is someone cleared for sports? And we're going to cover that as well. All right, so we're on the right track, and you're asking the right questions. So immediate red flags. So these are things where a lot of times people have concussions and they don't even recognize it, and they don't go to the hospital and they don't get it checked out. But here's a couple red flags. Let's say we don't see any bleeding, we don't see any bump on the noggin, but our kid starts having slurred speech. They have a headache that's getting worse. They have nausea. They're vomiting. They might even have a seizure. A seizure could just be being still, like they're not responsive. It could be a full grand mal seizure. They could have a difference in their pupil dilation. So those are things that if somebody in your studio fell down or got hit in the head by the tower bar with full force springs, these are things we would want to watch for. First of all, I would just encourage anybody that gets hit in the head that hard or falls off of a reformer and hits their head on the reformer next to it. I've seen with a lot of these new boutique reformer programs that they're doing really intense activities with people that maybe should not be doing that intensive activity. They're there because their friends are there, and they're doing things that don't have any kind of support. So if they lose their balance in the standing work on the reformer with their foot up on a foot bar, doing something like Russian splits, and they fall down, well, how far away is the neighbor reformer? It's only like 3 feet. So I've seen them fall down and actually hit their head and get a concussion on the frame of the reformer next to them or from the floor. So these are things that are not out of our scope. They're going to happen. Hopefully they don't happen in your studios because you would be wiser than that. You'd make sure there's some safety precautions taken. But those are things that we'd be looking for, those red flags. The professional boundary. Movement professionals, non-PT and MDs, do not diagnose, right? So the idea is that it's not my job as a physical therapist to diagnose that they have a concussion. And it's certainly not a Pilates teacher's job to diagnose a concussion. What is our job? Somebody gets hurt, we send them to the right person with the right scope of practice. I'm going to send them to emergency room with a head trauma. Even if it's just suspicious, I'm going to send them there to make sure it's clear. Probably not even urgent care. I'm probably going to send them to emergency with a head trauma. I don't want to take the risk because if they have a subdural bleed, no longer is this about a concussion. This is about traumatic brain injury. And so it could be very serious. And it might not manifest right away. It might manifest in 10 minutes or half an hour or an hour. Contradictions, high impact movements, inversion, that's a big one for us as Pilates and yoga teachers. Any kind of heavy Valsalva maneuvers, so powerlifting, closing your throat when you're lifting something heavy in the first 72 hours. So those are flat out contraindications. Somebody that had a concussion, got sent to the hospital. We are not going to hang you upside down from the trapeze table. We're not going to do elephant. We're not going to do inverted V. We're not going to do rollover. We're not going to do short spine and long spine. We're just not going to do that, right? No matter even they feel like they're great. Hey, I could do this. You're not going to do it. You're not going to put their head below their heart, right? I would even go as far as saying use the wedge the Balanced Body makes that has a little pillow that fits in between the headrest and the shoulder pads to be able to give them a little elevation of the head in relation to the heart. If you have that, I would have that in hand. All right. So the shift. This is some of the new information that's out there from the dark room to prescribed movement. And this is why it's important for us to understand this. Movement is essential. It used to be that we believed in the cocoon method. And this wasn't that long ago. I have friends that have had concussions in the last 10 years that were forced to go into the cocoon method. That means that they go into complete darkness, no light, and they have to rest for, more than 48 hours of strict rest. They can't actually do anything, right? And that they found that this is not healthy, that it does have a tendency to lead to things like depression, which I've seen the depression associated with the cocoon method. So if you hear somebody saying that, you can dispel them and say, I don't think that's the current treatment protocols for concussions. Let's look it up and find out what's out there. A common test or protocol that's used is the Buffalo Concussion Treadmill Test. This is basically looking at symptom threshold of the heart rate. And so there's a very specific test. They get on the treadmill. We're monitoring their blood pressure and their heart rate. And if there goes into a disassociation of those two things, we stop. And that requires somebody that has the expert training in doing that. So again, if somebody's having irregular heartbeats or their blood pressure is real high and their heart is beating slow, it's like it just doesn't make sense, that you want to get them attention professionally and medically. Got a couple more questions here. I'm loving it. Let's see. I have Elena. Hello, Elena. When we saw a concussion, we referred to a traumatic brain injury. What about bones concussions? Shake after a traumatic hit, kick, strike, if the bones are not visibly broken. So the concussion, first of all, any kind of brain injury, like traumatic brain injury, is going to include the effects of a concussion, right? The more severe the traumatic brain injury is, you're also going to see things like vascular bleeds, trauma to brain tissue, any kind of penetrating objects like a bullet or a knife or a hammer. Those are all things that, or it could be, look, I saw somebody get their face practically ripped off with a tower bar. So they were doing all the things right, and they were standing over somebody with a spring adjust from the top, and the bar was down, and it slipped off the foot of the patient, and it came up and it caught right underneath the cheekbone, and it just filleted the cheek off the face, cut a huge dash into the side of the eye. She's lucky she didn't have any eye damage. So there is incredible force in some of the equipment that we use in Pilates. And so you could see these type of injuries even in an innocent accident when you're trying to take the precautions on these things. So what I'm saying in response to Elena's question is, if you have traumatic brain injury where we see that the skull's been broken or we see a major contusion, you can bet that they're going to have concussion signs and symptoms, but they're also going to have other signs and symptoms, and particularly the symptom of death if you don't get them to care right away. If they have a subdural bleed or they have an internal bleed in their brain or damage, there's a big risk of permanent neurological damage, et cetera. So the sooner we get them to the ER room that is responsible in the trauma center, the more likely they have to have better outcomes. Whitney, my dear friend Whitney Valvelle. I'm working with a newer client who had a TBI and speech impediment from a bad accident years ago. Is there anything in particular that we need to look for? It seems that she still has quite a bit of trauma in her body. So again, you're looking at something that was considered and diagnosed as a traumatic brain injury, not a concussion, a more severe traumatic brain injury. So you could think of things neurologically like a stroke or multiple sclerosis attack, and where there's some permanent damage that could be done to the brain from this injury. And where that injury took place would determine sort of like what the prognosis is for that person to get better. What we do believe in is neuroplasticity. So after these type of injuries and strokes, we believe that if we continue moving the body, if we continue creating purpose, that the nervous system will find new communication channels and will strive to be functional. It doesn't necessarily return to what it was before, but we definitely see people improving their function. Madeline Mahmoud Al-Qadi, I hope I said your name right, Madeline. What are the early signs during a Pilates session that tell us the brain is benefiting from activation versus being overloaded? That's a fantastic question. I'm going to go there in a minute, and if I don't completely answer it, let's leave your question up on the board. If I don't answer it completely, I'll come back and I'll hit it with a little more precision. That's a great question, Madeline. All right. So here is some of the applications for us as Pilates teachers and yoga teachers, movement teachers. Is 2-point rule. I was explaining this a little bit earlier, and this might answer your question, Madeline, that during a session, if symptoms like a headache or dizziness or fog increase more than 2 points on a scale of 1 to 10, the activity needs to be scaled back. And so that's really it, right? So if they're having a good time in a class and they're not having any increase in symptoms, we're doing the right thing. We're good. We're good to go. But if they start, and you need to educate them on this. You need to ask them before they come to class, if you know that they've had a head injury, is, where are you at today in your headache, your dizziness, your fog? And they give you a number and you educate them and say, because they're the only ones that can tell us if their number goes up 2 points. So we're training them and saying, hey, while we're going through the exercises today, at any point in time that you feel like the headache is getting a little bit worse, you feel like the fog is getting a little bit worse, you feel some of these signs, let me know, and we're just gonna back off a little bit. Now notice I use the term back off. That doesn't mean stop necessarily, but you back off to the point that they go back to that discomfort threshold if possible. If they can't get there, then you stop. And hopefully, when I talk about things like neuromobilization, I talk about touch and go. We're moving that nerve into a place where we create the tension and we take it off. We don't stretch nerves. I would say the same thing with the concussion scales, that we don't push them trying to think that we're going to get them better when they're having worse headache pain, right? Pain is going to be an adverse effect. Fogged brain is going to be an adverse effect on them getting better. Yeah. Now we finally come to the answer. I think, who asked me about vestibular? I forgot who asked me this, but vestibular ocular considerations. So as Pilates and yoga teachers, we have to be careful of rapid up and down movement, particularly the vestibular system. So a lot of times the vestibular system gets affected. hence the nausea, the dizziness. You can imagine that if the axons are not communicating real well between the vestibular system in the brain and some of the other aspects of the brain, that we might experience dizziness, we might feel nausea, we might have some eye problems and vision problems that accompany that. So I'm going to show you something in a second. But a good tool is visual fixation. So with my patients that have had head trauma, those things, it's like when they're getting out of bed, when they're getting out of a chair, when they're getting off of the sofa, when they're getting off the toilet seat, is to pick an object with your eyes and focus on it while you're transitioning the movement. It seems to have a huge effect on the vestibular ocular reflex, which tends to be what gets wacky, and we lose our balance and get dizzy and sometimes fall down. And that's the last thing we need is somebody with head trauma to fall down again. So those are some important things, sort of key. I'll show you an image in a second of what that would look like and what abnormal would look like. Proprioceptive training. This is probably one of the biggest things, is just the brain mapping itself and becoming familiar again. What's a closed chain exercise? Where is the knee moving and tracking? How is the arms moving through arm arcs? Where's my head in space? How is my squat looking? How's my sit to stand looking? Where are my hands in space? Can I do some tactile things? Can I write? Can I play all the foot intrinsic games with my feet? All of those things increase proprioception. We also have a lot of toys that we use to increase proprioception. So think of like the Eric Franklin balls, the prickly balls, the different things that we use, just the OPTP kind of things that we have of the cushions for instability. All of those can help us increase the proprioception. And then the last one I have here is the breathing for the vagus nerve, and integrating diaphragmatic breathing to help recalibrate the dysregulation of the autonomic nervous system. So remember how I said the oblique trauma in a concussion can get to the brainstem where the hypothalamus is there. And the hypothalamus is the control center for the autonomic nervous system. So if we tweak that or we slow down the axonal communication there, we're going to see some asymmetries and asynchronous movement of things like heart rate, respiratory rate, hormone release. All of those things can be affected by a closed head injury. So again, what do we do as Pilates teachers? Well, we start synchronizing the breath. We do diaphragmatic breathing. We do the internal shower. We work with breath facilitating movement. We try to coordinate their breath with their movement to see how we can facilitate it and make it easier for them to roll up or to get out of a chair or to get up off of the reformer. All very important things. So, Madeline, I hope I answered your question there. If I didn't, you can send me another message, but I think we got that. Let's take a look at the vestibular ocular reflex real quick. So what should happen is that when I'm focused on something and I turn my head, my eyes stay. Like right now I'm looking at the camera and I turn my head and my eyes stay on the camera. In a concussive state, many times, if you turn the person's head, their eyes will move with their head, and then the eyes will come back. We call it saccade. It will come back to the focal point. So that's a very simple test that we can do even as Pilates teachers when we're telling our client that maybe had a concussion 4 or 5 days ago and they're coming in for their first Pilates class, is when you get up from the reformer, make sure that you find a focal point. Keep your eyes on that as you get up on the side of your reformer and watch them closely. So if their eyes are on that and their head moves and their eyes don't stay on that object, like they come off of it and then they saccade back to it, you know that there's still some head trauma that is causing balance disorders, dizziness, nausea that come from that disassociation of the VOR. I do this sometimes on purpose. Some of you have taken classes with me where when we're doing spine rotation, I'll take you over and rotate the head and I'll have you move the eyes back and forth as fast as you can. And some of you feel like you want to throw up because it could be nauseating. But what happens when you release the VOR, all of a sudden the thoracic spine gets another 15 degrees of rotation. So it's sort of like teaching the VOR is meant to maintain stability of vision while we're moving. That's what the VOR does. So the vestibular is interpreting movement, and the eyes are interpreting vision. And the idea is that the brain and the head and the body's moving, the eyes are going to stay fixed on the object they're watching, right? So I can move all around and I'm still focused on the camera. That's normal. And sometimes what happens is we get more dependent on our eyes. It restricts the movement of our body. So this is what we see sometimes where we lose our rotation in the thoracic spine. We lose our rotation in the lower extremities, where if we scramble a little bit as a trick. Now, don't do this with somebody with a concussion. I'm just explaining why you might have been with me in a class where I did a little VOR scramble to be able to get more thoracic rotation. Somebody that has a concussion, they're going to have a hard time tracking. So if you move your head, and they should be keeping their eyes on that, on your finger, and they can't do that, and they have what's called the saccade, and the eyes come back, you know that there's still some delay. The axons are not delivering that message as fast as they should, right? So you can sort of check on them every once in a while and see how they're doing and give them the chore of trying to maintain that. And believe it or not, the task of trying to fixate on something when you're moving actually improves the VOR. So you're treating that at the same time. All right, multidisciplinary team and future tech, right? So what we're looking at here is this is a collaboration. You know, you're going to get somebody that had a head trauma. You're not their doctor. I'm not their doctor. They have a doctor that hopefully was diagnosing them and is treating them, and it's become quite a specialty field. So we're excited about the idea of now having physical therapists that are trained in concussion rehabilitation, that work with neurologists that are trained in concussion, athletic trainers that are on the field that are trained in concussion treatment for athletes, especially children. And so it's a team effect. And this is where, even in the pathokinesiology course, what I'm hoping to do is to raise the level of knowledge, just like we did today, to raise your level of knowledge that you could sit down and talk to me as a physical therapist or to the doctor. You could ask an intelligent question and say, I've got a patient that you diagnosed with a concussion 2 weeks ago. They're coming in to do Pilates. Is there anything that I need to pay special attention to regarding their, dizziness, their visual fixation, the VOR, anything that you have a special test that you want me to do, just to do a status check when they come in that would be simple enough for me? That's impressive. That's super impressive when you're talking to a medical professional about that. Ask the client, is it okay if I talk to your physician? The physician's assistant is more than likely going to be talking to you, but it's impressive for us to go to them and say, I got a new client and they're coming in, you're their physician, they've given me permission to talk to you, they want to start doing Pilates, they've been told that it's good for recovery from a concussion, and I'd like to get just a little information before I get started with him or her. That's such a powerful place to be. So powerful. 2026 tech trends, brief mention of wearable biometric monitors, looking at the tech data that we have now, their sleep habits. I would strongly encourage somebody that had a concussion to have some kind of Aura Ring or Apple Watch or those kind of things that are keeping track of things that you can look at and see. Is there a regular heartbeat? Is there their breath pattern we can measure now? We can look at their stress levels. We can look at their sleep patterns. All of those things can give us a lot of information that have to do with this. Now, the last point that I want to discuss here is this idea of return to play versus return to life. This is really important for us, and I think sometimes more important for like the physical therapist that thinks their job is to get this person back on the playing field. I'm talking a little bit more about athletes. But the idea of return to life really has to do more with restoring the ability. When we think of our ICF model and we think of participation, return to life, we're talking about ADLs, activities of daily living. We're not talking about the recreation yet. It's not like saying, hey, let's get you back to normal, and normal is going out and playing contact football. That's not what we're saying. We're saying normal is you can get up, you can dress yourself, you can bathe yourself, you can feed yourself, you can transport yourself, you can get to work and do your work, provided it's not too intense, right? So if you have a work that is requiring you to crawl underneath a house and replace plumbing, or you have a job that is high-rise construction, I'm going to put more delay on you because I need to know that there's more healing that takes place, right? So this is really important that we can't, that an athlete, for example, can't handle the stresses. They can handle the stress of daily life. They can't handle the stress of going back out on the football field or the soccer field, right? So we look at this comparison between these two things, and we look at the return to play. This is sort of the apex of their return. And there are some very specific guidelines that have been given to us from the experts in concussion. But the definition is the safe, cleared, and structured return of an athlete to full contact, high-intensity competition. How do we know when that is, and how do we stage that return to those activities? So there's 7 things that I'll show you here. I hope you can read them. I know they're a little small. But the first one, and if you're thinking of sort of the steps of rehab from a concussion, cognitive rest. We give them a little bit of rest from things like computing and that kind of stuff. We don't push them beyond that 2-point scale. Then daily activities. Then they go into light exercise. Then they can start running. They can do non-contact training, so they can start running their drills. They can start doing some of those things. And then when they get clearance is when they can go back into the game. That would include things like martial arts, jiu-jitsu, boxing, where we have a lot of concussions. And these concussions, often the multiple concussions create a much more severe degeneration of the brain over time. So this is why in our pediatric and our sports, we're really trying hard to make sure that we are tracking how many times they really have had closed head injuries, because it is now showing to be a predictor of things like long-term dementia and other types of brain dysfunctions for individuals. So when we see boxers and football players, we can almost track them and show that the ones that are having dementia and Alzheimer's early is that it probably correlates to the number of concussions they had, but also to the shortness of time between concussive injuries going back too fast. So that's one thing with our children. I can't emphasize it enough. We can get them training, we can get them participating, but we don't want them to have another concussion, not too soon. That's probably where most of my brain damage came from, is I had concussions too frequently. All right. The time is yours. We have about 5 minutes left. I went a little longer than I thought. But what are some things we want to be careful of as Pilates teachers? And you can just put it in the chat session. I'm looking at the chat here. But what are some things that we should be cautious of based off of the lecture today? I see Katie Santos wants to do the political thing here where, how do we get the pro teams to mandate that players stop headbutting each other? When you look at rugby, it's an incredibly physical contact sport. I'd be interested, they purposely do not hit heads because they don't have the same kind of helmet gear on. So it'd be interesting to see what the incidence of head trauma is in rugby players and soccer players that also become very physical compared to American football. All right, what do you think? What are some things we want to be careful of as a Pilates teacher? I gave you a couple of them. Dum, 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 dum. Anybody? Good. I see some starting to come in. Good. Rapid head movements, inversion, evaluating the 2-point scale. Thank you for remembering that. Gradual load. Yes, ma'am. That is what we do in Pilates. We are the gradual load, graded load kings and queens. We don't diagnose, and not to stretch too far. Non-inversion. Good. All right. Here's the next question. This is more important. What is it that we should do? What are some of the indications for clients? And this is one of the things we're going to bring out in pathokinesiology over and over again, is not only do we know what the precautions and contraindications are, we know what the indications are. Keep asking about pain level. Thank you, Maria. That's perfect. Yep. We got to sort of stay in their face a little bit so that they can be responsible. A lot of times they'll come in and they're so stubborn. I don't know why clients are so stubborn. They want to be normal and they're not normal. And so we have to be able to explain to them ahead of time, I'm going to ask you about 15 times today in class. And I don't want to do it to embarrass you, but I need to grade your response. Listen to your client, energy level to tiredness, ask about symptoms, focus on that. Yep. Check in with headaches. And what kind of movement should we be doing for proprioception and for VOR? Yep, there we go, Katie. Use our eyes to assess as much as our ears. Good. Looking to see how they respond. If you see things like they're doing arms, arm arcs, and especially if they have the connector, right? So the connector is fantastic for this, by the way. And I'm not just doing a plug for Victor, but when you can't cheat and you have both arms in a strap or both feet in the straps, and they are independent of each other, you can identify asymmetries that are happening in their proprioception, which might be lost. So things like that. I see Charles put cross patterning, very good. Closed chain movements, Diana, thank you. Yeah. You guys got it. You know what to do, right? Now it's just experience. So we just got to, tell people that we want to work with that. I see Whitney put Elizabeth Larkham's VOR techniques. That's where I learned things from, was Elizabeth Larkham. All right. Let's see. Sarah had one more question. Did I not answer that? Presumably those VOR tests are also applicable to a client post-stroke. Absolutely. If the stroke is anywhere close to the vestibular system or to the brain's just an amazing instrument. And we look at things like how people problem solve, how they remember, how they speak, how they hear. There's all types of different kinds of injuries, focal dystonias that happen from different types of injuries and trauma to areas. So, this is just the icing on the cake. Let me finish by basically saying that, I really feel called to this and feel the responsibility to, as a legacy, is to be able to prepare a new level of practitioners, any movement practitioners, from the physical therapist to the dance teacher to the personal trainer. That's what pathokinesiology is about. It's a year-long study. It's a certification, and it's preparing everybody in all of those movement therapeutics and activities to be really educated, understand what action potential is in a nerve, understand what an axon is, understand how the vestibular system works, understand how all the different systems of the body work. So I'm excited to tell everybody that as of right now, 4 p.m., the registrations are open for the early adopters, which is everybody in the Pilates Hour. The early adopter will run through Monday at 4 o'clock. So you have till Monday at 4 o'clock to get the early adopter pricing. After that will be early bird. It'll be a little bit more expensive. And the goal is to make it accessible. So we've made it so that there are a 6-month and a 12-month payment plan that can keep it really affordable. We're going to go from the first course is really looking at normal, so physiology, biomechanics, movement. The second course is looking and diving deep into pathologies and their effect on the systems of the body. And then the third and fourth is really looking at the critical reasoning skills, very interactive for us, and it is completely virtual. What that means is that you could be anywhere in the world participating in this course with me. I will be leading the course. I will be leading the forums once a month. It'll be live. Those will be recorded as well if you can't make those. You pace yourself with the course. It's not too heavy of a load. Every quarter, we start a new course. There's competencies built into it. And by the end, my goal is that you feel really confident in the work that you do as a Pilates teacher, as a personal trainer, as a dance teacher, as a physical therapist, as a PTA and OT, that you feel really comfortable in working with these populations and know when to seek for help and when to bow out when it's outside of your scope. To really have that confidence is my goal, and to make that communication between the medical professional and the movement professional is seamless. So I hope to see you on that. Again, I'll be back next week. I have a wonderful program set up for the Pilates Hour over the next couple months that I can't wait to share with you. really amazing guests, a lot of them from outside of Polestar, Tracy Mallet, and just some really, really great people that are going to come on and join me and continue to bring you the light that you want. So in closing, hopefully you'll join me in the pathokinesiology course, but above all things, live aligned and be kind, and we'll see you next Thursday on the Polestar Pilates Hour.